Unit 6, Part 2, Older Adults. So this one's super simple. A lot of it's going to be stuff that we have talked about before or that you've heard before. I know a lot of y'all work in geriatrics. So older adults, right? Age doesn't define function. Some people do really well, some people don't. But overall in ages, we do see increased susceptibility to being sick, to disease, right? The body just gets tired. There's a lot of loss, change in roles, independence. Can you drive anymore? And we also see diminished senses. The elderly are not immune to mental health problems. Depression is super common, right? There is actually such a thing as post-stroke depression. And we often can confuse dementia in the elderly with depression and delirium. They all can get mixed up. There is an increased suicide risk with age, especially those above 65 and especially males, right? And in this population, for every one suicide, 3 to 4 more are attempting. And they could be passively suicidal. We talked about passively suicidal a little bit more. That's that I'm just not going to do anything. I'm going to stop eating. I'm going to stop drinking. I'm just not going to take my meds. And I'm just going to let myself die. We have to be super cautious. We have to assess these patients, especially with that passive suicide, to make sure they're eating, to make sure they're drinking, and to make sure they're sleeping. Anxiety, right? Fear of falling, fear of being left alone. SSRIs are one of the first meds that we use with the elderly because they're better with side effects. We have to be super cautious with benzos. They're just not safe. They're very inappropriate. And sometimes you have some of the elderly who have been on benzos for a while and it's really hard to get them off it. Delirium, we have a whole separate section on this, but this is a time-limited medical emergency. We can often confuse it and label it as dementia and disregard it. We could see confusion, them falling, right? We could think it's normal. But remember, any sudden change in the elderly, we have to investigate. We have to find the cause and we have to treat it. Because suddenly, right, they just don't start hallucinating. Dementia, Alzheimer's, those are chronic, slow, progressive conditions. It shouldn't happen suddenly. And delirium could be caused by infections, right? UTIs are one of the most common. Could be caused by a stroke. It could be caused by new meds. Alcohol use disorder, we don't really have that on here, is huge. And we're seeing higher rates of alcohol use in those over 65. Honestly, just because those who are like 55 to like 75 drink more. And as the younger ones get older, it's carrying on. Pain management is common, right? Arthritis, it just gets old, can't move as well, chronic pain, ADLs can be affected, and that increases, right? It increases stress, sleep disturbances. Oftentimes, we just assume pain's normal, right? Oh, it's arthritis, it is what it is. But we have to look and see what we can do. Non-opiates are best, right? Tylenol is preferred, but we have to watch the liver. Opiates are indicated in severe pain, but we have to watch long-term opioid use in general. Physical therapy, exercise, heat, cold, guided imagery, a bunch of things we can do, and we have to take a look for it. We got pain assessment. That should be nothing new for all of y'all. Things to consider. Caregiver burden. It's hard for caregivers, right? Elderly are at such high risk of abuse because of that caregiver burden, right? It costs money. You're exhausted. The physical work of doing it. Ageism is huge, right? We're not going to go hire someone who's 70 for a new job. Med reconciliation, we got to look at. What are the meds? How do you take the meds? Telling them to throw out expired meds. Right? Polypharmacy, they use multiple different medications and sometimes they're using multiple things that will have increased side effects. So like serotonin syndrome is a huge one because if they're on one med that increases risk of serotonin syndrome, and then you add another med and another med, they're at higher risk. Having one caregiver increases the risk of abuse, so we need to talk to families about respite care and day programs. So our neurocognitive disorders. Delirium. It's often reversible, right? We've already talked about this. We have to look at the underlying cause. We have to treat early. Cognitive impairments, infection, older age, fracture, polypharmacy are all risk factors. And this is all of a sudden change. It's abrupt onset. Disorganized thinking, poor executive functioning. Are they hallucinating? Are they stripping naked and walking around? We have to, with delirium, do a complete medical assessment to see what's happening. Right? So when we do this, inability to pay attention, disorientation, can they carry on a conversation or not? We talked about illusions versus hallucinations. Hallucinations is kind of me sitting here and being like, the voices in my head are telling me to do something, or I see someone standing in the corner. Hallucinations. Illusions is like that cord on the ground looks like a snake. The branches on the tree outside the window look like a person clawing at the window, right? It's like an optical illusion. Is it the pretty woman or is it the old ugly woman, right? Your mind kind of plays tricks on you. Illusions, there's something usually there. Is it a person in the corner or is it a coat rack, right? A coat rack with a coat and a hat on it, an illusion, we might think that is an actual person. Physical needs, we see an increase in symptoms, heart rate, flushing, hypervigilance in these patients. We got to keep the environment calm, right? Turn down the lights, make sure they have their glasses and hearing aids, watch for anxiety. So diagnosis, especially nursing diagnosis, safety is priority. We got to keep our patients safe. Fluid and electrolyte, sleep, communication, fear. And what do we want? We want them to be safe and free from injury. We have to treat the cause of delirium. We have to assist with ADLs, right? If someone has a UTI, we need to make sure they're up and going to the bathroom and getting fluids. I will talk over and over about nutrition with the elderly because it does tend to suffer, right? When you're living alone, no one wants to eat healthy and good food. Everything else, we've said this before, communicate simple, direct statements. Well-lit environment when it needs to be well-lit, right? Make sure we're kind of dimming the lights at night, but we want to make sure they can see if they're walking in the dark. So dementia is that broad umbrella term. We can't assume it's a normal part of aging. We have to rule out depression. We have to rule out another medical card. Another medical cause. Getting my tongue tied today. So what are some typical normal age-related changes or signs of dementia? Well, for the most part, a lot of the things on the screen is normal, right? Sometimes forgetting names or appointments, but remembering them later. Age-related appropriate change, right? Having a specific way of doing something. If you've been doing something for 60 years, right, you're going to be frustrated when your routine is changed. Trouble understanding visual changes can be an age-related change. And we can see the occasional bad choices, right? My grandmother decided not to renew her flood insurance and she lives in a flood zone. Right? So we see these and it's normal, right? Occasionally you're going to be like, wait, what was this person's name? Oh yeah, right? Or forget that you have an appointment. When it gets more extreme and you get lost in your neighborhood and you can't find your way home, dementia. So risk factors, genetics, there's a hereditary component. We also see it after cardiovascular disease, history of TBI, with diets, right? Someone who's socially engaged is less likely to have Alzheimer's disease. And Alzheimer's is caused by that deficiency of acetylcholine. We got 3 kind of main stages. Early stage, you're just starting, right? You're struggling with that recent memory. What did you eat for breakfast? Did you even eat breakfast? You know, if we teach you something new, you're going to forget about it in a few minutes. Moderate to severe is where you see the facial, spatial, loss of language, some psychotic features, right? The agitation and wandering. In the late stage, pretty much is bedbound disorientation, incontinence, difficulty swallowing and walking. So especially there's some strategies we can do, right? In the late stage, we want to make the patient comfortable. In the early stage, we really want to be reorienting the client and the family. Right? And teach the family this is how you can reorient the client. This is how you can get them to kind of be more comfortable with what's going on. When we assess these patients, we have a bunch of symptoms that we see. Confabulation, right? You are unconsciously doing this. You don't quite know what's going on, so you're making up a story or an answer in place of an actual memory. Just kind of make yourself feel better. Aberration, constantly repeating a word, a phrase, a gesture. Agraphia, a bit diminished ability to write. Aphasia, loss of language. Apraxia, purposeful movement. Agnosia, You can't recall an object. You don't remember what the cup is. Hyperorality, you want to put everything in your mouth. Hypermetamorphosis, you want to touch everything. Sundowners, that increased agitation at night or later in the evening. We have to look at assessing cognitive functioning and memory, right? And with these patients, and I know y'all are going to say it, we got to rule out, is it Alzheimer's, is it dementia, or is it delirium? So if there's a sudden cognitive status change, right, we got to do that medical workup. We got to get vital signs. To rule out or in Alzheimer's, we'll do a CAT scan, we'll do a PET scan, do some mental status questionnaires, and our intervention. Person-centered care. We have to talk to the family, right? We have to distract the patient. If a patient with Alzheimer's is doing something they shouldn't do, right? Distract and redirect them to something else. What are community supports? How does the family in that early stage Alzheimer's, how do they reorient the patient appropriately? If they're not eating finger foods or soft foods, we got to look at nutrition and weight. Super important in the elderly across the board. Home for the family, falls, driving, cooking, sensory stimulation, all of those are potentially dangerous. Wandering, medical alert bracelet, locks on the doors, alarms, make sure everyone kind of knows, hey, look, we have a silver alert. This elderly person has lost silver. Exercise, super important, right? Children's books. It kind of keeps them connected. We do have some meds. Cholinesterase inhibitors increases the amount of acetylcholine, and these work well in mild to moderate. This is your donepezil. Nausea, vomiting, diarrhea, insomnia, fatigue. Common side effects. Bradycardia, incontinence, syncope. We got to watch these patients and also make sure we're telling them not to take ibuprofen. We got to make sure we're watching their pulse. We got to make sure they know you can have that nausea, vomiting, and diarrhea. Will slow the progression of the disease, but it does not stop it. Namenda works with glutarate. This works again in moderate to severe. A lot of the same side effects: dizziness, agitation, headaches, constipation, confusion. I can't even say these. Nimzeric, a lot of the same side effects. And again, it works on our glutamate and our cholinesterase or acetylcholine. So what do? Aromatherapy, calming interventions. We want to have the optimal level of functioning for them, and we want to delay further regression. This is a chronic disease, Alzheimer's and dementia, chronic. They're going to get worse at some point. We want to do our best to slow down that process. We have to look at an individualized patient plan. We did those case studies. They are available under Module 6. If y'all have any questions, reach out. Otherwise, hope y'all have a very good evening.